Now, good morning and welcome back to everyone that was here yesterday, or those that were watching online. Now, before we start, may I ask any co-participants or legal representative who wishes to apply to submit a question to do this by 12:30 today. Such applications should be made using the form provided in Appendix A to the Rule 9 procedure relating to these hearings, which is published on the Inquiry's website. Now, with that, good morning. Good morning, Mr. Turner.
Good morning.
When you're all ready, please start.
Thank you, my Lord. Good morning again. Professor Woolhouse, I think we had just come to you yesterday when we closed, and we were discussing potential alternative strategies to the COVID-19 pandemic. I wonder if you might give us your thoughts in terms of what alternatives were available to respond to the pandemic.
The one that I think you want to talk about here is a strategy called cocooning. Do you mind if I challenge the premise of your question?
By all means.
That strategy, and many strategies designed to protect vulnerable people from the effects of COVID-19, are not alternatives to lockdown. It's not the point of them. So, whatever your strategy is to suppress the transmission of the virus, which was part of the strategy of lockdown, whether it's lockdown, all the other ways of suppressing the spread that we've talked about, or indeed nothing at all, it is always a good idea to protect this subset of the population that is exceptionally vulnerable to the virus. These are not either-or options. They're not alternatives. You can, and in my view, actually you should, do both. And of those two sides of the equation, the one that we focused on during the COVID pandemic, as we've discussed, was suppressing transmission, particularly through lockdown, but other social distancing measures at all. And in my view, we grossly neglected the imperative of protecting a small number of vulnerable people that were at great risk. They were never alternatives. You could always do both. That was my recommendation, that we should do both. But it wasn't presented that way in debates on this topic. So I'd rather not characterise this as an alternative to lockdown. It's a necessary addition to lockdown to protect vulnerable people. And there are reasons why it's necessary. So for that, we need to think about the things that lockdown didn't do very well. So the one that we're all very conscious of is it didn't do a great job of protecting care homes. And one of the reasons, of course, is that is a lot of the functioning of care homes involves people moving around and making contact with other people. Lockdown doesn't stop that, so it didn't do a good job of protecting care homes by itself. The other thing it didn't do a good job of is protecting people in hospitals. Hospitals are very complex, large environments like care homes. In fact, they have their own dynamics. So when we were doing all those measures of how much lockdown had suppressed the R number, the transmission rate in the general population, that suppression did not apply when you did separate analyses for either hospitals or care homes. And we did a lot of this sort of analysis with colleagues in Scotland. And in fact, the R number in those settings, hospitals and care homes, stayed above 1 throughout a lot of lockdown. It was only when we properly got a handle on what was going on in those specific environments that the patients and the staff got the benefit from the intervention. Lockdown was not enough for those settings.
Was there any particular reason identified?
Again, it all boils down to the fact that there are necessary contacts to be made. A hospital is a busy place, particularly when it is under pressure from COVID. A lot of people going to and fro, a lot of infection control. This is difficult to manage. It's a setting where it's always been difficult to control the spread of infectious diseases, which is why we have the concept of infection prevention and control, and why we have units in hospitals to try and manage it. It's historically always been difficult to do that, and it is particularly difficult in the case of coronaviruses, I'm sure experts there will agree. They're well known for transmitting well in hospital environments. So lockdown did not by itself protect those settings adequately. But there's another very important place where lockdown didn't work as well as we'd like it to. And I'm going to give you a statistic here. So, of the people in the community, vulnerable people in the community, who died from COVID during the first wave in Scotland where we did the analysis, the majority of those got infected, they acquired their fatal infection during a lockdown. Now that makes sense at one level because we have lockdown when the pressure of the virus is high, but what it tells you is lockdown may have partly closed the door, but it absolutely didn't fully close it. It wasn't that we locked down and those deaths of the vulnerable people in community suddenly stopped. They absolutely didn't. They continued. So lockdown was not enough to protect vulnerable people in the community. So you want to do something else. If lockdown is your preferred method of suppressing the virus, it's not my preferred method, but if that is the strategy, it's not enough of a strategy. Whatever else you do, if you protect vulnerable people more, you save lives. And I believe that many lives could have been saved during the pandemic if we'd had more attention on this minority that were so vulnerable, particularly in the community, but also in hospital and care home settings. And the reason we didn't is because, we discussed this at length yesterday, that the epidemic, the pandemic, was being presented as something where everyone's at risk, and the job is to suppress transmission for everyone, and that will have a big impact on the problem. It did not take account of the fact that a small minority of the population were particularly vulnerable. Why were they so vulnerable? Why? Another way of putting this is, when you do the sums, is lockdown did suppress the number of cases in all parts of the society, but the group that it least reduced the number of cases was the most vulnerable people in the home. Why? Well, because they can't self-isolate, which was basically the essence of the lockdown strategy. They can't do that. They need care in the home. That's why they're vulnerable. The vulnerabilities are to do with age, but also to do with comorbidities, other diseases that they might have, disabilities that they might have, and so on. So, to give you an example, which is, I won't name names, but it's fairly close to home as far as I'm concerned, an elderly woman living at home during the COVID pandemic who has to have 4 visits from care workers every single day. That is one of the least self-isolated people you could imagine in a lockdown situation. And she was very, very vulnerable. Very, very vulnerable, but she had to have those visits. They absolutely couldn't be stopped. So how do you make that safe? Well, some of the care companies were very, very good at this. And they were very, very diligent at making sure that the people they sent to that woman and many, many thousands like her, hundreds of thousands like her, were not infected. So the people who came to do these home visits, originally they were screened for symptoms because that's all we could do, and then there was the PCR test. It took ages to roll that out to that sector, the care in the home sector, but it did get there eventually. And the thing that really changed it was the mass testing later on when people could test. But they took great care to make sure that their staff were not infected, so they wouldn't infect the people they were visiting in their homes. That's cocooning. You protect the people that have to have contact with this very vulnerable minority, and that's a very important way of keeping the mortality rate down. And we didn't do nearly enough of it, in my view.
You've mentioned there that, again to paraphrase you, Professor Woolhouse, cocooning is in effect protecting those that are in contact with others or ensuring that the risk of transmission is reduced from those others. Do you accept that those others are in contact with other people and that risk will therefore be there?
Yes. So the people who form the cocoon, as it were, are indeed a special category within the epidemiology of the virus and the pattern of sickness and death that it's going to cause. They are a special category. There is nothing remarkable about that. We identified healthcare workers as a special category very early on, and rather too late, we identified care home workers as a special category for the same reasons, and it's the same to care of the home workers, and it's also true, of course, for anyone who is an informal carer, and there are millions of those in the UK, and they are in that position too. They can't abandon the people they're caring from, but that means that they can't isolate from them either, and so those people also have to take special precautions. They are a special category, and that happened. And again, I'm not going to go into the details, but close to home, an example of someone I know very well who did exactly that, who realised that, well, in order to keep my caring duties going safely, I'm going to have to make sure I don't get infected. That was a spontaneous reaction by an ordinary member of the public, and it was repeated all over the place from stories I've heard since. People realised this, not a difficult concept, and so that's what people did. They took special precautions to protect themselves because they knew that they were needed as carers, and there was a hazard in that. And what should have happened, in my view, is the government should have recognised that from very early on and given these people special status. So where were the informal carers in terms of being given masks, being given access to testing, being given the sort of support that I think Sinetra was talking yesterday, where if they did get exposed to the virus, never mind infected, but if they thought they'd been exposed, there was somewhere else they could go, particularly a multi-general household or something, where they could stay clear, they could quarantine themselves, and in that case, that the caring duties could be passed on temporarily to someone else. So we had a mechanism for identifying those people, which was all the contact tracing. So people knew that they had to self-isolate. Well, what if the person who has to self-isolate is a carer in the home worker or an informal carer in a domestic setting? Well, then their duties have to be replaced. And that was a big issue, because if people felt, well, yes, I should self-isolate, but I have to care for my relative or who I'm living with, then, well, there's a tension there, and there shouldn't be. It should be, oh, I'm worried that I'm infected. I can't do this. I better ring the number and get the support in I need while I isolate myself for 14 days or whatever the requirement was. That should have been there, and it wasn't there. So as a result, it became practically very difficult for vulnerable people in the community to successfully isolate themselves, to successfully partake in lockdown. They couldn't self-isolate. They needed the care, and the care itself, as you've identified, was potentially a way that the virus could get in, and that way had to be stopped best we could.
Do you accept that if this strategy was adopted, we would have certainly more and potentially a very large number of people being treated as a special category?
No, we'd have less. The whole objective of that strategy was to protect vulnerable people, to reduce the people most likely to end up in hospital if they got ill, the people most likely to die. So there'd be fewer cases in that group.
Fewer cases, but in terms of the approach of the number of people that were, for example, having to be tested or have availability of PPE, etc., at the commencement, at the initial stages of the pandemic, if we're treating more people as a special case, those involved in a cocooning situation, which didn't happen, as I understand it.
Yes.
There may be some practical difficulties in doing that.
So first of all, I hope we're not getting sucked back into the alternative to lockdown. I'm not, at the moment, discussing lockdown at all.
I understand that.
The lockdown is in place. We're discussing how to reduce the death toll despite the lockdown being in place. So let's be very clear. There is not a trade-off here at all.
No.
Okay. So, but you're pointing to a slightly different trade-off, and you're quite right, that accessibility to PPE and particularly accessibility to testing was very limited, very restricted in the early stages, and there would then be, and there were clamours for testing for one group and another group and so on, and that would have to be balanced. But the best you can do with it, the more lives you save. The reason we got into that position, of course, was in the early months of the pandemic, January and February in particular, we weren't planning for this sort of eventuality. So we hadn't built up the capacity for testing, particularly, Testing is very, very powerful in the context of cocooning. That's ultimately what you do. We hadn't built up the capacity. We hadn't anticipated the need. And that's a failure of all of us. That's a failure of the advisory systems, the public health authorities, everyone who built pandemic plans over the years. Some of us around the table who did that. But we didn't anticipate this need at this sort of scale. So that can be put right. We can, in the future, work out that we're going to need that. And I do, it's an ever so slight digression, but I hope you'll allow me to. I do want to come back to this role of testing, because I think David mentioned it a bit yesterday. We went through 3 phases in the pandemic. We went from very little testing available, so the only way you could identify potential cases either through symptoms or through contact tracing. So, so we had to do those as rigorously as possible, but they would not be enough. We then went through the PCR test, which was centrally managed, took typically up to 48 hours at least to get a result, and was very cumbersome, and was not really suited to protecting, well, even healthcare workers and care home workers, never mind people who are cocooning others in their homes. It could be used that way, but it wasn't ideal, and it was difficult to scale up. So what I actually suggested as early as May 2020 was that we needed mass testing on a scale of literally millions per day. I have to say, when I first proposed that, I got ticked off by a Scottish government official, this was part of my advisory group roles, who told me quite firmly, Mark, this is a serious committee. We have to have serious suggestions. Well, that's what I was told. It wasn't a serious suggestion. And I said, I'm afraid I think we're going to have to rethink what's feasible. What happened, of course, was then in, I think it was August 2020, I'm allowed to mention Matt Hancock? Yes. Matt Hancock actually introduced something called the Moonshot Programme, which was an idea for scaling up testing on the sort of scale I was talking about. So I was very pleased to hear about it. This was, I think this isn't too misrepresentative of what SAGE did. They slapped it down. They were not supportive of mass testing. They identified all sorts of difficulties with it. Nonetheless, the government went ahead, and they trialled it in Liverpool in November 2020, which was somewhat successful. And this is using now the lateral flow tests, the sort of mass testing that we all became very familiar with because we did it ourselves. So the system was up and running by November 2020. The advisory systems were still not promoting this mass testing, and so we all ended up in lockdown that winter. The mass testing capability was there, but we weren't using it. We eventually rolled it out later in 2021, and it came into its own during the Omicron wave. And this comes back to another very important discussion we were having yesterday about the public being informed, and I think I'll call it the penetrance of the information and the learning, how far that gets into the furthest corners of society, and basically does it leave some people behind? They just don't have access to either the information, or as Claire very rightly pointed out, or the ability to act on the information. So, that's a very legitimate question. What was the penetrance of these interventions? Well, during the Omicron wave in Scotland, mass testing was freely available. I'm sure many people in the audience used it. And the reason I'm sure is because at the peak, 80% of the Scottish population were testing themselves at least once a week. Penetrance was very, very high. People worked out the value of knowing their infection status, and a lot of them used it. 50% of them were using it multiple times a week. Now, what does that enable them to do? Well, I don't think anyone is testing themselves and going to ignore the results. That is that is literally the millions of people that I was advocating almost 2 years before, no, year and a half before. That is them doing it. So now they have knowledge of their own infection status. Now they can manage the risk to themselves and others. Now they know that it's not safe to undertake their caring duties. Now they can do their cocooning properly. So, and that was achieved by giving people access to information on their infection status. Is any of this new? Was this made up during the pandemic? Well, the last bit, not. So, for example, the biggest pandemic of our time, HIV/AIDS, the public health mantra for controlling HIV/AIDS is safe sex and know your infection status. Those are the two things we do. Safe sex is, well, the equivalent of COVID. It's all the measures we know to reduce the transmission from one individual to another, including PPE and everything like that. So, yes, we had that. And know your infection status. Yep, that's what we could do. That's what we could do with mass testing. So it's an absolutely standard public health combination to do that. It was used in the biggest pandemic of our times and should have been used more in the second biggest pandemic of my lifetime as well, but it wasn't. So it's normal in that. The concept of cocooning, well, unlike some other interventions, like lockdown, that were suggested during the 2020, that is in the textbooks, but I can't say it's I wouldn't give it a high profile in the textbooks, but the concept is there. But we absolutely adopted it with the vaccine rollout. So the vaccine rollout in the UK had, I don't know if you remember all this, the list of priority groups. And the public health agencies worked their way through the priority groups. Right at the top of this were the most vulnerable people that we've talked about, including in the home, so recognising their vulnerability. But at the same time, there were also healthcare workers, care home workers, and after a little bit of campaigning by those of us who thought they were important, care in the home workers and informal carers. And they got priority. Now, the hope was, Sinetra will say that hope wasn't met, that the people who had been vaccinated would be therefore less likely to pass on the vaccine to their charges, to the people they were looking after. And that was the reason why all those groups, well, part of the reason. In the case of healthcare workers, there was a risk to them directly as well, particularly in care workers. But the main reason was to try and protect the people around them. And that does depend on the vaccine having an effect on transmission, which, as Sinetra has quite rightly pointed out, the effect is not far from perfect, but it's not none. There is some effect on transmission. So what I'm saying is when we rolled out the vaccine, the strategy involved cocooning. Now, if that was the right thing to do with the vaccine rollout, why on earth weren't we rolling out cocooning with other means of reducing transmission rates, of which we've discussed for great length over the last day and a bit? So it's very puzzling to me that this intervention, which was adopted in the context of the vaccine, was not adopted using non-pharmaceutical interventions. It should have been.
Before we do anything further, if I ask any more questions, can I just tell everyone in the hall and remind the people around the table that we're going to have a fire alarm test. We can't put it off. It's for the whole building at 10 o'clock. So we'll go silent and be deafened for 2 or 3 minutes. My apologies, but out with my control.
I do warn you, it's quite loud in this room for reasons I'm not quite clear. Thank you, Professor. Professor, you very fairly indicated that plans could have been put in place for this. The steps could have been taken. You mentioned the role of the vaccine. Obviously, that was some period later in the pandemic. Do you accept, therefore, that there were potential practical obstacles early in the pandemic? Can I mention a comment made by Professor Ian Hall to the UK inquiry? And he notes, I recall that Mark Woolhouse was a passionate proponent of cocooning, but the practicalities of it were challenging. He stated that the UK government could and should have done more to protect the most vulnerable during the second wave. And with benefit of hindsight, it is always possible to argue that more could and should have been done. This is particularly true in relation to care homes and in light of the impact that the second wave of the COVID-19 pandemic had on those in care homes. However, while shielding is conceptually simple, it is a challenge to implement. A chair's briefing from later in the pandemic in December 2021 also set out the practical difficulties of shielding. The reality is that care homes had staff and visitors who have lives and interactions outside of the home. For cocooning to be effective, it would be necessary to cocoon staff, their children and so on. This is unlikely to be practicable at scale Anecdotal reports of some staff living on some care home sites were reported, but not all care homes had land for such accommodation. These practical difficulties would apply at any stage of the pandemic, particularly if there was no national precedent. Would you accept that, or would you challenge that statement?
What a counsel of despair. I'm saddened to hear and read that. I really am. He talked about the benefit of hindsight. The best you can do with the benefit of hindsight is to say protecting the most vulnerable people in the country is difficult. With the benefit of hindsight, we could come up with a watertight plan right now around this table, with the benefit of hindsight, that would work. And we could explain how you build up to that in the early stages of the pandemic. That's what you do with the benefit of hindsight. You don't say, oh, this is all too difficult. Remember, I'm not talking about this alternative to anything.
Yes.
No, I'm just doing this as a necessary intervention. It's also factually wrong. So there was, I'm sure many members of the audience and others in this room are very well aware, there was a very significant problem with care homes in the first wave. It remained a challenge in the later waves, but relatively speaking, we were much more on top of the problem. So I'm not quite sure what Dr. Hall is saying. We absolutely did get better at protecting care homes. We were just rather slow to do it, but we absolutely got a lot better, and he knows that better than anyone. He studied this. So it's a very strange comment from that point of view. We also got better at treating people at hospitals. We also got better at infection control in hospitals. We also got better at protecting people in the community, because we were all learning as we went to do this. So, no, with hindsight, yes, this absolutely could be done.
In the context of the pandemic, though, and you've mentioned obviously the changes in benefits and advantages that became available during the course, do you accept that the availability or the potential to do cocooning at the outset was more limited than became later in the pandemic?
As I've just described, yes. As almost everything we did to control the virus was more limited at the beginning, and we got better at it as we went through time. Yes, of course I accept that.
In that context, you described for us yesterday the relatively, I don't think I misstate, early discussions that you had with the Chief Medical Officer, and His Lordship has obviously heard evidence already in terms of the progression. We know the dates of lockdown and the dates that steps were taken. Do you think anything could have been undone earlier that may have affected the feasibility of cocooning?
Well, I raised the prospect of cocooning with the Chief Medical Officer very early on, either possibly early February, might even have been late January. That was entering the conversation. The reason was for this very obvious thing that I've said, but I'll stress, is that if you're going to have a policy that depends on people, it's called reducing their contacts, not having close contact with so many people, isolating themselves as best they can, certainly for households to isolate themselves. If you're going to have that strategy, people like the case that I described at the beginning, who need 4 visits from care home workers at all, simply cannot do that. So it was obvious to me that the concept of shielding, as it was implemented by the UK governments around the world, was never going to work, because that required vulnerable individuals to try and isolate themselves as best as possible. And that was never going to work. So from very early on, cocooning seemed to be the way forward that we was most likely to be successful. And yes, so that did enter into discussions with the CMO here from a pretty early stage, well before March.
As I say, I'm conscious that it is 9:59. I don't know if that clock is
Could we
bang on.
sit in a few seconds solemn contemplation or meditation, whichever is
You
your
might want to put your
fancy.
fingers in your ears.
Well, we are assaulted. Right, good. Thank you all.
Thank you, Lord. We were talking about your interactions with the Chief Medical Officer. Professor Woolhouse, what steps do you think should have been taken around the time of your initial discussions with the Chief Medical Officer and onwards?
Yes, but it's not so much my interactions. I mean, there was a lot of scientific consideration of the problem and what should be done about it that was circulating and widely discussed. There was an awful lot of chatter about what should be done. It's not just me sitting by myself thinking these things up. The community is turning its attention to this. There was a lot of concern by the lack of testing capacity and the importance of surveillance of the cases in the community from a very early stage. That all comes back to the situational awareness that we were talking about, so we weren't aware of that. There was insufficient attention being paid to the evidence that we already had, that this was particularly a disease that attacked the elderly and the frail and the vulnerable, and therefore those people would need protecting. We learned this during February that this was the case, but we didn't act enough on that, and we didn't foresee at that very early stage, or at least I didn't explicitly foresee the need for mass testing. So that's a lesson learned. But it became obvious to me that we needed it soon. A month or two after we went into lockdown. But we were slow with that. With hindsight, collectively we were slow. We should have realised the need for that earlier and made sure or pressed the government hard to introduce it. But having said that, I'm slightly sceptical that if I had persuaded the Chief Medical Officer to say to the First Minister, Professor Woolhouse says you need the capacity to test half of Scotland every single day for this virus, I would have got even a worse reaction than I did when I actually suggested it a month later. One of the lessons I have learned about giving persuasive scientific advice to officials and politicians is you do have to deliver it in bite-sized chunks. And I think I personally made a mistake of giving them the whole package in one go, and that was indigestible. I think they needed to be led along the path a little bit more gently.
You've very clearly indicated that what you're proposing isn't an either-or. It's something that could be done along with lockdown. Do you consider if measures such as cocooning had been put in place, and I appreciate there's a number of factors involved in that in terms of the availability of testing and the like, but if those could have been put in place, that would have avoided or reduced the need for lockdown, in particular in March 2020? So
the evidence I've given before comes from a scientific paper we wrote on this topic, and the authors of the paper are many, and it's important that I identify not individuals but what their roles is. So one of them was myself, one of them was a leading public health expert who led one of the most effective disease surveillance programs. One was a senior figure with SPI-M, one was an advisor for SAGE, and one was infectious disease clinician here in Edinburgh. So that's a pretty expert group, is what I'm saying. And our estimation, because we didn't have the data, but our estimation was that aiming to reduce the risk of transmission to the vulnerable groups through a cocooning policy, we should aim at 50%. Couldn't do it 100%, completely agree, that's correct, but we should have aimed 50%. Because 4/5 of all the deaths occur in the group that we're now talking about, that would have reduced the death toll in Scotland in that first wave by 40% if we'd achieved that. So our expert judgment was that was the sort of level we should be aiming at. So I would say, yes, we could have, in the first wave, reduced the mortality by about 40% is my best estimate through that method.
And would that, if steps had been taken early enough, would that or could that have avoided that first lockdown?
Well, again, I'm not arguing to make.
No, I appreciate your notes, but
if you want to avoid the first lockdown, you act earlier. I said that yesterday.
Yes.
That's a different problem. But what it does do, to back off my position slightly there. It makes the debate about the exit strategy for lockdown, and that's actually how we ended up introducing it into the advisory system. Because the point about exit strategy was everybody recognised that if you allow the transmission rate to creep up, okay, the epidemic may not take off, but there's, transmission rate's higher, so there will be some, even if it's relatively small, increase in death and disease. So that, clearly isn't a desirable outcome at all. So how do you offset that? And that's one way you can use, right, okay, well, you put more money, more effort into protecting the vulnerable people whose exposure is going to be incrementally higher because you're starting to relax. So it was a way of enabling the exit strategy without it leading, in fact, that's what everyone feared, a significant surge in deaths and disease. Nobody wanted that to happen, and so it's one way you can offset that. But you don't have to offset it, you can just do it. It doesn't have to be an offset at all. Just do it anyway, it's still going to save lives.
Can I just be clear, you're talking there about exiting from lockdown. Would you accept, therefore, that lockdown was necessary in the circumstances that we were in at that time?
Well, I did accept it at the time, but I didn't have some crucial information on that, which was just, we discussed this yesterday, just how much people's behaviour had already changed. And I didn't know that, in fact, lockdown would not change it any further than it already had. So if I'd known that, I would not have supported at the time. But again, information we didn't have and should have had at that time.
Just to be clear about that, you're saying you didn't have that. Did anyone have that information at that time?
No, but we could have got it.
Right.
If we'd asked the right questions, we could have got it, but we didn't.
I think it's probably implicit from what you've said already, but I'll ask expressly, does the availability of testing and PPE have any impact on the ability or the likelihood of success of a cocooning strategy?
Absolutely does, yes.
And would that have impacted the ability to roll that out early in the pandemic?
No, it wouldn't have impacted the ability to roll it out. It would have impacted its effectiveness, how effective it was. And as I say, from personal knowledge, people were spontaneously rolling it out, as you call it, anyway. People worked out that, well, to protect the person, the vulnerable person that I live with or that I care for, I'm going to have to protect myself. But people weren't supported in being able to do that. They just had to do it for themselves. They weren't given the support that would have helped them do it better. And the PPE and the testing are exactly the kinds of support that would have required. But it goes further too. We talked a lot around this table about supporting people to comply with restrictions and to comply with the measures being taken. What was actually done in the pandemic for this shielding category, which I said was not the right way to approach it, and I think they got offers to help with their grocery shopping, and that was it. That's not a particularly comprehensive package of care. New York City had a much more comprehensive care package. They even included a dog walking service. So for people who had to self-isolate or whatever, who couldn't do that part of their lives, it was very comprehensive. So we could have done much more to support people who were, that was in the context of people who were trying to self-isolate, but also people who were trying to cocoon. We could have done much more to support them in that, and we didn't do it.
How do you consider that individuals who would be candidates for cocooning would be identified?
They had already been identified to a significant extent simply by the very dramatic change in risk with age that we've identified. It very quickly became apparent that there were other risk factors. So, but this, when I say quickly, I mean the first half of 2020, not February 2020, not so after lockdown, not before. But we've discussed this, a whole load of comorbidities. Basically, elderly, frail and infirm are the high risk factors. David's quite rightly pointed out obesity as a big issue. Cardiovascular disease is a big issue. Diabetes is a big issue. These were all identified in formal studies very quickly within the first 6 months. Again, in lessons learned, that information is incredibly valuable for targeting efforts at controlling the disease where it's most needed, so people with those conditions are absolutely targets, as were, for example, individuals with Down syndrome, which perhaps wasn't expected, but they turned out to be extremely vulnerable to this disease. So it is very important that the public health, the scientific community, establishes who's at risk early. And there is a trade-off now. The better and the quicker we can do that, the better we can target the interventions where we need it. If we don't do it, if we think everyone's at risk, or we behave as if we believe that, then it's not going to happen.
Do you consider that the information that would be necessary to make that identification is available? His Lordship has heard evidence previously, for example, regarding shielding lists that were created and the inconsistencies and non-participation of certain individuals in respect of those lists. Do you envisage any difficulty or data requirements that would be required to implement a scheme such as this?
As I said before, you are an awful lot of the way there simply by age. And we did absolutely know that before lockdown. That is by far the biggest risk factor. But the others are important too, and they enable you to target much better, and that they took time to establish. I mean, I don't think there's any surprise about that. They did. So as go back to my previous answer, the quicker we can establish it, the better we can identify that. If those were the only factors, and we had to study for 6 months in order to identify who was at risk from this virus, then actually you'd be right. Then, okay, yes, lockdown was a reasonable strategy because we didn't know who was at risk and how they could be protected. But that isn't true because of the age one, which we absolutely did know and is by far the most important.
In terms of participation in a cocooning scheme, you've mentioned already the I suppose, aspirational figure of 50% in terms of participation. But do I take it from that you would be envisaging a voluntary rather than a mandated scheme? Advice rather than requirements?
I'm not sure how you would mandate it and why you would want to. I mean, people wanted to do this, as far as I can tell. So what I'm advocating for is they should be supported to do it. It's completely different from shielding. This idea that people have to self-isolate. It's accepting that people need a certain number of contacts, whether it's particularly for care, physical care, often social care as well, and making those contacts safe. That's what it's about. And the way you do that is by making contact with people who haven't got the virus.
Did you or do you have any information regarding whether that 50% number was realistic?
No, because we didn't implement it. But I would defend it. I mean, it's the individual. Sorry to go back to a data sample size of 1. It's very poor science and poor statistics, but hopefully it's instructive. The individual I mentioned, the very vulnerable individual, had 4 care visits a day. Got that person through all the time until that person got her vaccine, the first vaccine. It works.
In the context of the pandemic, I appreciate, in respect of a new pathogen, that will depend on its own circumstances, but in respect of the pandemic, by way of example, how long would you envisage the cocooning scheme, if I call it that, would require to last?
In the COVID context?
In the COVID context.
In the COVID context. You can implement it in some form, as we say, it will get better, but you can implement it in some form from a very early stage. And I suspect that many people would have chosen to implement it all the way through to the rollout of the vaccine. That would be my expectation. Again, anecdotally, but I'm sure we all know stories of vulnerable people who basically didn't set foot outdoors for that entire period and suffered greatly as a consequence of that. So that would be my expectation, is that many people would choose to do that.
in terms of you, and I appreciate it's not an either or, but in terms of its utilisation, would the vaccine effectively be what you'd be anticipating to provide a natural end date for a cocooning approach?
Well, the easy answer is yes, but your next question is then what if it had taken 4 years rather than 1?
You've anticipated.
And that is a very legitimate question. The people I spoke to, and Sinetra's more of an expert on this than me, who knew about the vaccine development, were talking about 1 year from a very early stage. I was actually quite surprised at that myself. It's not my area of expertise, and that sounds very optimistic to me. But it was achieved. So I would have bowed to greater knowledge and chosen the 1 year. I note that current pandemic preparedness plans, particularly a high-profile one published by the G7 a couple of years ago, talk about the 100 days mission. So their current aspiration is to develop a vaccine for the next pandemic within 100 days. It's a worthy aspiration. I think it's clearly optimistic, but it also talks about the end point as being the availability of the vaccine and not the successful rollout of the vaccine, which is a rather larger mission, which inevitably takes months. So there's an extended period beyond the rollout of the vaccine, beyond the vaccine becoming available. And just to hammer that point home, in the UK, more people died of COVID after the vaccine rollout started than before. It's a very striking statistic then. So the availability of the vaccine, the first jab in the first arm, was not the end of the ordeal at all. That started to come in about 6 months later, when sufficiently large numbers of the population had had the vaccination that we were starting to see a really big effect on it. But an awful lot of people died after the vaccine rollout started. So the 100 days was never going to be the end of it. But with hindsight, clearly a year is not an unreasonable target.
You mentioned, in effect, that we were already adopting a cocoon-like approach in terms of the NHS, in terms of protecting healthcare workers and the like. His Lordship has already heard evidence from healthcare workers regarding the extraordinary steps which some of them took to protect themselves and their families, some living away from home for periods of time. Do you envisage any significant impact on those who would in effect be offering the cocooning services?
So again, a large part of the point of the cocooning exercise is, even in the context of a lockdown, is to allow vulnerable people to have more contact safely. That's the point of it. Otherwise, if you're not trying to do that, then you just take the actual strategy of shielding and say these people should just isolate themselves completely. And cocooning is the antidote to that. It's not contributing to that, it's solving that problem.
And please correct me if I've misunderstood, but if one is protecting those individuals, and in order to do so, part of that is ensuring that those that are in contact with them are providing less risk, in effect. And early in the pandemic, there was no vaccine, there was limited testing, for example. But even when that became available, is it not a natural consequence that those people who are going to be in contact are having to effectively restrict their lives in order to offer that balance?
Yes, it is. But in a context where all our lives are restricted, as it happened, because we were all in lockdown. Sorry to keep throwing anecdotes at you, but another anecdote. So in the situation I was describing, sadly, a family member died elsewhere, not of COVID as it happened, and there was a funeral. It was the days when only a small number of people were allowed to go to funerals. And the individual I'm thinking of chose not to go to that funeral because that individual prioritised her cocooning responsibilities over that choice. Very difficult choice to make, but that's the one that some people choose to make.
You've mentioned care homes. You've mentioned the fact that one of the reasons why people in care homes and vulnerable individuals are at risk is because of the number of contacts that people have with them. His Lordship has heard, and indeed I'm sure everyone around this table is aware of the restrictions and stories from care home residents and their families and their inability to meet them during the pandemic. Would your, would the scheme, would the cocooning approach have had any effect, do you think, on the ability of family members, for example, to visit families in care homes at the time, if that approach had been taken?
Yes, it's a subtly different question because now you're talking about biosecurity of care homes, which involves, as you say, family visitors as well. And I'm not sure how you would certify a family member as saying, well, I have been protecting myself and I am safe without access to testing. That is the obvious thing to establish that someone's safe. And of course, coming back to it, once we got the mass testing, we were all doing that routinely. So when I first went to a care home during the pandemic, what did I do? Of course, I tested myself for the 2 days beforehand, as everyone did. So with access to those testing, it's absolutely doable, and to make visits to care homes safe. And we did it. The care homes required that we did it. There were notices on the doors saying, don't come in here unless you've tested negative. Quite right too. So with testing, it can be done. It's much more difficult to do that when you don't have, as I say, a way of certifying yourself as COVID-free, and all you can say is point to the fact, well, I haven't actually seen anyone for the last week. So I accept there's difficulties there, but I'm not sure that they're any greater than they were in practice anyway. I don't think they're adding to the difficulties. The cocooning is not adding to the difficulties. It's just part of the whole biosecurity setup around care homes.
You mentioned that, unlike the term lockdown, cocooning might have been something that would have been seen in textbooks, for example, prior to the pandemic. Are you aware of any countries using cocooning during the COVID-19 pandemic?
Using cocooning? Oh, you mean as a formal strategy?
Yes.
No, not. It wasn't adopted, but by governments, but it was adopted by people a lot. So this was something the public was doing. So there's a concept, I really hope I get this word right, called Ubuntu. And it was written up in the British Medical Journal, which is one of our leading medical journals, by a group of public health experts and scientists from Ethiopia. And they were writing, completely independently, their alternative to lockdown, the way Ethiopian society would see it. And they said, basically, it's the duty of the whole village to protect the most vulnerable people in it. So I think it translates as "I am because of we," or something like that. Sorry, I should have done my homework before bringing this to you. But that was a concept they were advocating in the scientific press of a whole community taking steps to make sure that vulnerable people are not exposed to this virus. So I have absolutely no doubt that the concept was recognised and acted on all over the world.
Thank you, Professor. Professor Bambra, can I ask, do you have any views on how a cocooning approach might have benefited or otherwise affected vulnerable individuals during the pandemic?
I think we need to just be clear that we're all using the same term when we say vulnerable. because I think Mark's been really clear. What he's talking very much older, infirm people that are in a care home or are at home but are almost in a care home sort of situation. And I think that's different then from talking about communities that might be more vulnerable because of their socioeconomic status or ethnicity, right? So this is, I don't think we're proposing that certain suburbs,
no.
right? So I think if in your question, could you tell me which of these two different scales you'll want me to comment on?
Well, I think what I have in mind is that we've already acknowledged that in respect of a lot of these groups, these sort of comorbidities and the effects of the pandemic were greater in a lot of these areas. And I suppose what I'm asking is, do you think there's an advantage just in the round?
Mark's described the cocooning whilst also having a lockdown. That seems to me sensible to give that additional protection to the population group that Mark's described within also a lockdown happening. If it were proposed purely as an alternative, which so far has not been discussed, then obviously there would be more significant issues because it would be much harder for those carers to take the measures necessary for them to be sure or fairly sure that they weren't infected when they went into care home. Like they're on public transport, there's lots of other people on public transport, and then they're straight into someone's house. But that's not what's been discussed so far. But then when we talk about who had a vulnerability, obviously I've argued with my colleague Professor Sir Michael Marmot to the UK COVID inquiry and some of our recommendations there, that pandemic plans should have a wider understanding of who is at risk. So there's the clinical vulnerabilities, including age and frailty, but also because of what we know from COVID and from other pandemics, such as flu or swine flu, there is a clustering of risk within deprived, some minoritized ethnic communities, and so different measures need to be taken to support there. Now, I think it would be difficult to think of the practicalities of then cocooning on that sort of scale, but that's not what's being proposed from what I understand from what Mark's just said.
Thank you.
So I kind of feel like there's not that much. I've sort of done a very long answer to no comment, I think.
Thank you. Professor Woolhouse, can I just clarify, we obviously talked there about the initial stages and in terms of I think you've indicated very clearly that this was at that point effectively an augmentation and an additional strategy that could have been undertaken. In respect of what I think was ultimately termed the second lockdown, do you feel that could have been avoided?
The second lockdown in England or in Scotland?
Well, both, I suppose, but from a strategic perspective we're looking at.
Well, the second lockdown in England, which happened in I think November 2020, was avoided in Scotland because we didn't have it.
Yes.
So, answer to that question is a clear yes. Could it have been avoided? We did. And the reason for that is because here, the advisory group, the SAGE for Scotland committee that I sat on, was not clamouring for more lockdown in the way that the advisory groups down south were. So, and the outcomes in Scotland, if anything, were actually slightly better than England. So that lockdown was clearly unnecessary. We almost did an experiment to prove between Scotland and England that it wasn't necessary because the epidemiology of the virus in the two countries is very, very similar. So no, the second lockdown in Scotland began in January 2021. That was important because we now had the Alpha variant, which was significantly more of a public health hazard, and it was causing a lot of problems. So yes, you would, in my view, immediately re-implement your cocooning strategy there, because now there's an enhanced risk to everyone, but particularly still to the elderly, the infirm and the frail. But the other technology we had at that time, which would not only augment cocooning, but actually allow people to intervene directly was the mass testing. But as I just explained, that hadn't been embraced by advisors down south or by the public health authorities. So although the technology had been available since November, it hadn't been made available on the scale needed to avoid the second lockdown in Scotland. Yes, it could have done, because in my view, it was what kept us out of lockdown during the Omicron wave. This very, very intensive mass self-testing that was going on. As I said, 80% of the population testing once a week. In my view, that's what kept us out of lockdown during Omicron, and it would have done the same thing during the Alpha wave a year before, but we didn't have it. So the mass testing is really important here, because it underpins, as we've explained, it really helps cocooning. It makes that much easier to implement and much more effective. But it also has a much wider role in allowing people to know their status and assess their own risk, how risky they are to others. And by the way, that's another thing we were discussing about whether people protect themselves or whether their motivation is to protect others. Self-testing is undeniably something you're doing to protect others. And that was a very, very popular thing to do in Scotland. So there's no question that people were willing to protect others. That's why they were testing themselves. So the self-testing, I think, was the biggest omission in terms of trying to keep ourselves out of the second lockdown.
Thank you. I'd like to move on now, if I may, to questions of investment, I suppose, is how I would term this, in terms of things that could have been done that may have assisted in terms of a pandemic response. Professor Heyman, excuse me a second.
Sorry, Professor, do you want to say something?
Could I just quickly add something to the cocoon? Thank you very much. I think that was a very useful discussion, and I think cocooning is very much part of a strategy of individual risk reduction, and it sort of divides those needing risk reduction into those who can do it themselves and those who cannot. And those who cannot, I think it's very important to pay. That's where we really need to pay attention to. For those who can, you just give them the means to do so. I think it would be, and what Professor Woolhouse has expanded upon in wonderful detail, is how we can recruit the tools at our disposal to achieve this. There are two things I want to say. One is that in terms, and it is very much an exercise in protecting others, and that's something we could have started to do well before, as soon as we knew there was a virus abroad that could affect people who needed cocooning. But how do you achieve cocooning? Obviously, you need a sort of standing crop of uninfected people, I think. But that standing crop can roll over. You can pay people, and one should, professionals, to self-isolate for a while. They can then go back to their homes after having done that, or ideally, after self-isolating, they would go and take on some of the duties of cocooning and then return to their lives. What I think would have been a disaster is if we relied on lockdowns, reducing the prevalence or the likelihood of a carer being infected in enacting cocooning. If we said, oh, look, we've locked down, so you can just come on a public transport to look after this vulnerable individual, I think we would have been in trouble. So while I agree that formally cocooning and lockdown can certainly happen together if there are other reasons for lockdowns, and had they not been so disastrous in other respects, I think it's very important to recognise that to rely upon lockdowns to reduce the risk of transmitting to another person, I think would have been quite a dangerous gamble.
Professor Heyman?
I might just add to this conversation because I think it's been very useful. And you know, if you try to summarize the excellent comments of Mark, Claire, and Sunetra, I think what you come to is an understanding that the government plays a role. And that's a role of knowing where transmission is occurring or finding where transmission is occurring and working to lock that down, to try to stop that from continuing. But at the same time, there's also a real need for the government to empower its people to do what they need to do to identify their own risk, whether they have a risk of serious illness or whether they have a risk of transmitting to others. And so that's where self-testing and all the different cocooning activities come in. And they can't be done by the government. They have to be done by empowered communities, people who understand. And so the government needs to spend time both on empowering its people and at the same time on identifying where transmission is occurring and trying to stop it. I think it's very important to understand that in the 100-day strategy, which is for a vaccine, it's also for a self-test, a diagnostic test. And that's extremely important because that can be used immediately when there's a pandemic. And it's much shorter delay usually to develop the testing than it is to develop the vaccine. At the same time, it's really important to understand that current thought is that almost all infections in humans have come at some time into humans from the animal kingdom. They may have caused a major outbreak, they may have not, but in the end, it's population immunity which keeps these infections at bay. And so to answer the question, to continue the question about vaccine delay, certainly shielding and cocooning would need to continue until there's evidence that population immunity is keeping this infection at bay so that it isn't causing serious illness in those who are vulnerable. So there are many different components, but it's really important for the government to sort out what it should be doing and what its people can be empowered to do. And as Mark said, they were already empowered to do that before as the pandemic began. Many times it's important to understand the capacity of humans to deal with their own health issues.
Thank you. Professor Bamber.
Thank you. I just wanted to return to one of the inequalities issues that would come through, and I think Sunetra sort of alluded to it with the financial support. Obviously, it is requiring carers, we did it with healthcare workers, but carers, to make considerable sacrifices. And I think we need to point out that obviously carers are very lowly paid, often working on quite poor contracts. I mean, the government's talked about that just this morning in the news around trying to improve the working conditions, basically, of carers. So if we were to be doing cocooning, that would need to be looked at, because otherwise we are asking for huge sacrifices from low-paid, often female, disproportionately ethnic minority women who provide care. So I just wanted to add that in as an element, and I don't think colleagues would disagree.
Thank you. We've got just a few minutes before the next break. I want to pick something up here just before we leave this section. And that's a question, I suppose, about what I've headed here, potential missteps. And really what I'm talking about is things that perhaps were done, that perhaps it might not have been done if we'd adopted different strategies or the like. I wonder, Professor Heyman, whether you've any comment to make, you may not, about the approach that was taken in respect of school children and whether knowledge of the levels of transmission from or to teachers and from and to school children may have been different with the benefit of hindsight.
In influenza, it's children who take the infection from the school, younger children who take it from their daycare centers or their schools back into their homes. This was the initial fear with COVID-19, that the same epidemiology would be occurring. However, it was found very early on that, in fact, schools were not a source of infection to the homes, at least the primary schools, And countries in many parts of the world, especially in the Asian parts of the world, began to open up their schools after an initial close down and found that their primary schools were not sources of infection to the families and most times kept them open. Discussions that they had in those countries included not only the government, but included the teachers' unions and a whole series of other groups to inform them and to keep them advised on what was going on in the schools and to clearly express the risk to those groups as well, because everyone was involved in making sure that there was safety for not only the students but for the teachers. So schools early on were shown not to be a risk factor in many countries in Asia, and that information was known in European countries, but for some reason was not acted upon, and I was not a part of any of the advisory groups in Europe, so I can't really tell you what the discussions were, but I think Mark would be able to do that possibly.
No, I think David summarised the understanding very well. It would be a long discussion to work out why that understanding did not fully penetrate the advisory systems in the UK at pretty much any stage of the pandemic. So the advice to close schools that the governments, certainly down south, were receiving was not aligned with the evidence that David's mentioned, and indeed a number of SAGE members vocally said that, but yet they were ignored. You did hear, because I happened to catch it, evidence from our colleague in New Zealand last week that he felt that teachers in New Zealand were at particularly high risk of being infected, which puzzled me greatly when I hear it, because that wasn't the evidence that I was familiar with. So I tried to do some research on it. I couldn't find the data that he is referring to for New Zealand, but we do have it for the UK. And compared with a completely random person, a member of the public in the UK during 2020, teachers were at elevated risk, but not compared with any other people-facing profession. So the most at-risk group that was identified in a number of studies were actually bus drivers. And the other thing that's not captured in this is, okay, teachers are at elevated risk, and I said many times this, the most dangerous place in a schoolroom was not the classroom, it was the staff room. And actually, there's an argument that in hospitals, the most dangerous place is not the wards, it's the canteen. So that's where the informal socialising has happened. COVID-19 transmission is very associated with talking. So the risk in a classroom is disproportionately from the teacher, who is basically throwing virus out if they happen to be positive. I mean, fortunately, the children are not at great risk of of disease if they are exposed to it. But there was one super spreading event in an Israeli school during that was associated with an infected teacher taking 3 consecutive classes and infecting pretty much all the children. But as David said, the route for children to teachers or children to their families at home was not a strong route of transmission. And one study in Scotland actually found, so it's an outlier study, but not that much of an outlier, that having children in the household was protective, didn't actually elevate the risk of the members of the household, it protected them. And there's a co-infection, cross-immunity argument that might explain that observation that Jeanette will be well aware of. So I think that became apparent very clearly, very early on. And of course, as you well know, many countries did not close schools. Sweden only closed them for basically sixth form colleges, but everything else it kept open. Denmark reopened them in May. Many other countries did the same thing, but we didn't. And that was against the evidence that was accumulating around the world at the time.
Thank you. Professor Gupta, I can see your finger wagging.
Just, yes, just to follow up on the notion of cross-immunity, which I would like to, I hope does come up a little bit. I mean, so this study, as Mark said, indicated that people who lived with school children were more protected. And this brings me to a point that, we do have a lot of cross-protection from exposure to related viruses. And I think one of the learnings from this could be that perhaps the sort of isolation that we inflict upon the elderly outside of pandemic times even is just simply does not lead to good public health outcomes. And obviously this is still a conjecture, so it would have to, I think it should be tested more thoroughly. And then steps that one could take, and these are sort of at a very broad level, would perhaps be to organise social activities that bring the elderly more in contact with the rest of the community. Because, I mean, this is actually something that's been known anecdotally anyway, that isolated communities always suffer more. So a level of pre-exposure is actually a very good thing. And I think one of the reasons some countries did poorly is because we do have a large class of isolated, vulnerable people who were less protected than they might have been had they had more exposure to the milder cousins of the invading virus.
Thank you. Professor Bamber, briefly?
Oh, yeah. Just that obviously the decision to close schools in the face of the evidence, obviously we might have the chance later, but just to point out that the huge inequalities that had, we talked a little bit about it yesterday, but we're seeing the legacy of that now in terms of children from lower socioeconomic backgrounds. But if there's time for that later, then...
Our next section is going to talk about the balance, and I think that probably comes straight into that.
Great. And are we going to talk about outdoor activities?
We can.
Brilliant. Thank you.
Very good. Keep you happy. 11 o'clock.
All right.
Microphone's ready, Mr. Turner.
Thank you, Molly. We've spoken for the last day and a bit regarding the potential non-pharmaceutical interventions, lockdown, that we could undertake. Implicit within those are that there are impacts on individuals and others in terms of what they can and can't do. And what I would like to discuss now is the impact of those, and indeed the balancing exercise which must be undertaken, or will need to be undertaken, in respect of any restrictions. If I could perhaps come to you first, Professor Bamborough, in terms of the approach that was taken in respect of the balancing of individuals' rights, do you feel that that balance was correct in the recent pandemic?
I think there were some areas where it wasn't correct. And one of the concerns that the wider public health community had and has from subsequent evidence is around the restrictions on exercise, for example, particularly around outdoor activities. As we heard from Professor Heyman yesterday, with the nature of it being a respiratory disease, there was always going to be minimal transmission outside, obviously particularly in more rural areas. But there was a blanket restrictions and obviously not very clear restrictions. Was it an hour in total you allowed out of the home? Or could you break that up into certain periods of 15 minutes? Flippancy aside, obviously what we see now in the data is an increase particularly in childhood obesity during that period and an increase in the inequalities by area deprivation, and that spike now has sort of been built in. It hasn't, we haven't got back to the trend as was before, so the inequalities were rising and there's a spike in that trend during the restrictions period, so it's associated with. Hard to see that it's not, at least in part, to do with restrictions on obviously children's being at school and the activities that they would do there, including getting to and from school, but also within school. But then the restrictions on basically being in the home, potentially 23 hours a day.
Thank you, Professor Heyman. Could I ask you, just following up from that? Do you feel that the restrictions that were put on children in particular, but others, in terms of outdoor activities, do you feel, with the benefit of hindsight, that those were sufficiently balanced?
I would follow on to say that they were not sufficiently balanced. In fact, transmission did not occur outdoors, and these outdoor activities should have been permitted. It was very spotty as they were. Some were able to walk dogs, others were not. It depended on I think, communities, and I think that's where the decision should be made, is at the community level. Communities should understand the epidemiology and know where there are safe places for people to go and where there are not safe places. So, forced versus voluntary, I think, is very important in this issue. People should be permitted to go where there is not transmission, and communities should understand where that transmission is not occurring or cannot occur. So I think that there were mistakes made in not permitting people to get the exercise and to get the outdoor, even in urban areas where they could go and be safe.
Does that mean that even if a lockdown was in force at a particular time, you'd still have advocated the ability to go outside and have outdoor activities even during that time?
Certainly, in all areas where people are locked down, they need to have the opportunity to get out and do exercise. And that includes sitting in a 2 or 1 bedroom flat in an urban area. It's absolutely necessary that people get out in a safe way, and they should understand themselves how they can keep themselves safe. And as Mark said earlier, people were understanding that very early in the pandemic. And so I think it comes back to the fact that government cannot replace the ability of people to understand and shield and take care of their own public health or their own health issues rather than having the government make decisions for them.
Do you consider, therefore, that rather than potentially mandating restrictions on activities, that should be left to the individual in light of the information? Or how would you envisage that being managed?
Yeah, individuals and communities, including all communities, need to understand the issues, and then they are able to respond to them. I recall the Mpox epidemic, which began to spread among men who had sex with men within the United Kingdom at a time right before the Gay Pride month of the summer. And because the groups were empowered to understand how transmission occurred, there was very little, if any, increase in transmission during Gay Pride month, although there could have been. People were protecting themselves because they understood how to do that. That could be extrapolated to the population in general, that if they understand, if communities can help people understand, they can then protect themselves and protect others.
Thank you. Professor Gupta, do you have any views in terms of the balance that was undertaken during the pandemic?
Simply on outdoor activities? Or? Well, I suppose my whole argument for what should have been done is predicated on the complete lack of balance, because many of the activities proposed, well, I actually think of it as a total, I mean, it started off with some sort of coherence, so staying at home does certainly reduce your own individual risk, but then eventually it became more diffuse, and the set of rules that were implemented seemed to be illogical, and as I said, were characteristic of what I would call a narrative collapse. And the reason I think there was a narrative collapse is because there was no consistent sort of logic behind any of it, and in any case, and on top of which, so that's one side of it, and this was the lack of balance derived, however, from also the costs of these measures. So lockdown as such, I think, was a huge assault on the lives of the poor and of children in particular. And I don't say that because of civil liberties being taken away from them, but just the actual material consequences on their well-being, mental, physical, and otherwise, and the long-term effects were profound. So in terms of that very basic seesaw, almost all measures that might have been taken would fail the balance test. But importantly, the measures that were taken, it's not really clear what they were set to achieve. To my mind, what was necessary, and has arisen from all these discussions, is that we needed a sort of standing crop of uninfected people to serve as carers to other people who also needed to remain uninfected for a period of time in order to avoid the consequences which we sought to avoid, which is deaths and severe disease from this pandemic. It is not clear to me how that would be achieved by stopping transmission at a population level in the first place, because what eventually leads us to the state of endemicity is the build-up of immunity in the population. Now, we've said a million times that SARS-CoV-2 is not one of those viruses that gives you full protection upon a single infection. You have to be reinfected over and over again to maintain that wall of immunity. But that wall of immunity is what is keeping us safe now. And that's where we need it to go. And stopping transmission in the general public, in the community, therefore needed to be justified at some other level. I can, and we are all making very strong case for stopping transmission, for preventing infection of those who would die or suffer severe consequences. We're making a very strong case and asking for investment to maintain, as I said again, I'll use the word standing crop of people who can care for such individuals if necessary, and certainly to enable their own family members or less informal, the informal caring sector, to be able to perform their duties. But I am still not clear why the goal of stopping transmission, what is the precise purpose of stopping transmission in the community, and also how, I'm not clear of the purpose, I'm not clear of how whether lockdowns are able to achieve that, and one thing I am clear about is the harm that lockdowns do. So, as I've said this right at the outset, given those three ingredients, which now we're talking about a different kind of balance, but just simply that in terms of the, I suppose two of them fall on the side of what would the possible benefits of stopping transmission be, and times the probability of whether you can do it at all, and what are the harms of those measures. And to me, the seesaw is like this.
Thank you. Professor Woolhouse?
It was a very strange time for human rights, wasn't it, the pandemic? The overarching human right in place in Scotland that period was the right not to die of COVID. And that seemed to be what drove all government policy here. The coming out of the authorities, as I was calling it yesterday, was the phrase that no COVID death is acceptable. Other deaths apparently were, and as I said, partly as a consequence of that, they actually rose in many circumstances, but no COVID death was acceptable. There is no such thing as zero risk, and we have never attempted to regulate society on the basis that there is. We have always accepted underlying risks. I was discussing with His Lordship yesterday the baseline risk of the lightning strike hitting at school or something. We don't try to manage society on the basis of zero risk, and in this case we were trying zero risk from one particular source, in fact COVID. It was a very, very strange time for human rights.
Can I just quickly, there was some of the language that was used in that regard, which is to talk about people's lives being expendable, I think created a lot of problems in people's minds, because, again, you were being enjoined to consider this as part of your, or to share some form of guilt in something that should not necessarily be thought of as inevitable, but is something that we live with. We don't consider people who are lost in traffic accidents to be expendable. It's just an accommodation we make within society. It's part of our social contract to try and aim for the greater good. And such language, I think, prevented that.
Professor Woolhouse, just picking up on a few things you said this morning. In terms of that balancing exercise, and you mentioned human rights, we discussed, in respect of cocooning, we discussed the compliance rates, might not be 100%. In terms of reaching a balance in terms of people's rights, would you be in favour of forced or mandated interventions, or do you think interventions should be effectively left to the individual with information provided to them?
So there are many public health activities where government gets very heavily involved in the delivery. The obvious example of that is a mass vaccination programme.
there's always been a debate about to what extent vaccination should be mandatory or not. I don't particularly want to make a personal comment on that. But I do firmly accept that there is a public good in having many people vaccinated with a safe vaccine as possible in many contexts. And we discussed the particular circumstances of smallpox eradication yesterday. So I'm dodging your question consciously, but I do believe there are public health interventions where there is a common good to be aspired to. How that is achieved, mandatory or voluntary, is up for discussion, should we say.
Thank you. Professor Heyman, can I just come back and ask you regarding Professor Willis's comment there regarding effectively a zero-death approach in Scotland. Was that your understanding as well?
My understanding was that there was an attempt to minimize serious illness and death, not to go to zero. But that was, as I say, I was not a member of the advisory groups here in Scotland or in the UK, so I can't speak for them.
Professor Bambra, could I ask you regarding pre-existing structural and institutional inequalities? To what extent do you think those should impact in terms of any balance the government might wish to make in terms of pandemic response?
Yes, so I would interpret them to be things like social inequality, economic inequality, including deprivation, but also racialised inequality. And for the UK work, the UK COVID inquiry work, we looked a bit into the potential role of structural racism in effect, kind of socially sorting people into higher exposure through their occupations, for example. So these things all played out. So when you get the comments like the virus doesn't discriminate, kind of the way society is structured means that the virus ends up being discriminatory in its effects. So these do need to be taken into account, kind of regardless of what the measures are. And we've discussed some of it in relation both to lockdown, but also in relation to any alternative strategies or supplementary strategies such as cocooning that we discussed this morning. So a lot of what I've been thinking about and recommended in my written work is around some of the mitigations that could and should be put in place in order to enable communities and individuals to protect, themselves, their families and their communities. Because it's not possible for everyone to interpret their risk or to self-isolate when they don't have, secure work, for example.
You've mentioned there that effectively the need for more support in order to enable some of these steps to be taken. Do you have any view as to, again, whether interventions by government should be mandated or voluntary?
It would depend to me on what the intervention is. And again, whether people were given the tools to be able either to undertake the intervention on a voluntary basis or indeed to undertake it on a mandated basis. So, for example, there's some evidence around compliance with the kind of stay-at-home order varied by socio-demographic group because, for example, women had a lot of caring responsibilities outside of the home, and indeed later they had to change that guidance. But I don't want to, go through a whole list now and tick off which I think would be fine to be voluntary, which I think would be fine to be mandatory. My point would be that we would need to think, ideally a priori, in terms of planning, about the inequalities aspects of any of these interventions, how they're delivered, implemented, etc.
Can I make one brief
Yes.
comment on that? I mean, the reason, I'm thinking in the context of a vaccination programme, but it applies more broadly, the reason why you might want to mandate is because people, in your estimation, are not complying with the measure in sufficient consequences. So for me, the first port of call is why not? And how can we change that? And often it's a case, and this came up again and again during COVID in the context actually that Claire was mentioning, in the context of self-isolation, which was extremely difficult for some people to do. This is when they're identified as contacts. Extremely difficult for some people to do for all sorts of social demographic reasons. So rather than, and that's what happened during the pandemic, rather than criminalise people who broke the 14-day quarantine rule, self-quarantine rule when it was there, well, why are they doing that? And can we actually support them so that they can manage to do what's required for public health and what we believe is required for public health? So I think in that sort of context, the mandatory element you've already failed when you have to legislate for it, because people are voting with their feet and saying, actually, we don't want, or perhaps more importantly, can't do what you're asking of us. And criminalising this is not going to help with that.
Yeah, mandating it doesn't mean it's necessarily going to happen.
Yes, it doesn't make it any easier. It doesn't make it any easier to self-isolate. It just penalises you for failing to do so.
Presumably, Professor Bamborough, the message is important as well, because if the reason for any particular restriction is properly explained and truthfully explained, and no doubt in means that are most accessible to the most people, it is more likely to be complied with, and therefore there is no requirement for a mandate.
I would hope that would be the case, Your Lordship. My concern now would be around the misrepresentation, particularly, for example, around vaccines that we get on social media. So even now, the NHS explaining why people should have MMR, for example, is then countered by people's daily interactions with false information about those vaccines. So there is that new hurdle, I think, even more now, even though it's only COVID wasn't that long ago, but the evolution of or decay of social media has had a role.
Thank you.
Just a quick comment about the mandating versus voluntary. I think that what's very relevant here is the size of the community, and I think David's comments about where these decisions should be made is relevant in that, both of these are manifestations of some kind of social contract. And I think the reason we mandate is because this is too big. Where are you going to get the consensus from or the buy-in from? And I think the buy-in that obviates mandating can occur so much, more easily at that sort of community level.
Professor Eamon.
There are mandates for vaccination for international travel under the international health regulations, which don't require but permit countries to require that people coming from an area, for example, with yellow fever outbreaks must be vaccinated before they can cross that international border. So there are precedents for mandates. There are also precedents for mandates in school entry for certain vaccines. So these are not a new concept, but they're set up in order to protect the public rather than the individual. And so I think looking at what goes on internationally is very important, and what's been accepted by the international community, that mandates in some instances are acceptable.
Can I just say one last?
Yes.
The other problem, I think, is that people think of mandate as being in opposition to liberty, and that it's a false binary. Mandates can be enacted by a society to provide something that will benefit everybody, and that doesn't have to be seen as a loss of personal liberty. I think it'd be quite useful to get away from that binary.
Professor Bamborough, you've mentioned the potential for comorbidities in certain communities. To what extent do you think that should bear upon the advice, instructions, mandates that are given And do you think those should be tailored for any particular groups?
Advice around?
Around responding to the pandemic. I'm thinking in the context of how individuals might be asked to behave in a pandemic, if we are talking about in contrast to being mandated to do something or not do something, if they're being advised not to do something or not to do something or not to do something, that context.
Then you would want that messaging, if that were the route you were to go down, to make it clear that, for example, if you have diabetes, then your risk is higher, you might need to take more care. But I think what we've discussed is it's not just about that person who's vulnerable, it's about what the others around them also do. So the knowledge can be useful, but you, again, as I've said before, need to be in a position, a context, be that social, financial, whereby you can act on that knowledge. And the other issue comes in is around when we're saying, for example, in the planning documents, it was all about, people with clinical risk factors, which, diabetes would come into. But you might not know you have diabetes, and you're more likely to not know you've got diabetes if you are in a lower income neighbourhood. You're less likely to access your GP, less likely to have screening, less likely to have testing, etc., for various illnesses. So you're less likely to know that you're someone at risk, if we want to put it in those kind of terms. So there are difficulties around a messaging that is, if you are this, you should do A, and if you're not, you should do B, because you might not know if you're A or B, or you might not even understand that kind of messaging.
In that context, do you think it's appropriate for government to distinguish geographically between groups in terms of the advice that's being tendered?
I personally think that geographical-based advice it can be useful. Potentially it's less stigmatising, depending on how you frame that. If you say that certain, like if you were to say that urban areas were more at risk, for example. But again, it'd have to be based on the knowledge that you have, and again, this openness about why you're saying that, why you're saying there needs to be a restriction in this community, but not another one. And we had a bit of that, certainly in England, when we had a period of what they called the tiers. But that, from my point of view, there wasn't enough explanation of that. And it's also an example of where the lack of support financially, in terms of, for example, the northern parts of England, somewhat famously with the role of the Mayor of Manchester talking about it quite publicly, were put into quite strong restrictions compared to, say, London, in the kind of lead up and post the second English lockdown, so winter 2020, but without the same furlough scheme in operation, for example, in that for people in, for example, the northwest and the northeast. So, and also without, I think, a full explanation of why the north had to have tiers, but when seemingly earlier on London was having a big spike and a problem, there was a national lockdown. But when the north was having problems, in effect, we were locked down. It wasn't a strict stay-at-home order, but I can remember, restrictions on how many people we could meet outside. Meanwhile, get images of people in restaurants and ice skating in London. So that might have been more acceptable for people if it had been explained better, if indeed perhaps it was necessary, but we've discussed some of that at length yesterday. So that messaging to different communities matters if you're going to put one geographical area into restrictions and not another. But it is something we've discussed as a way within outbreak control.
If there is a socioeconomic correlation between the impact of a pandemic on communities, and we've talked, and His Lordship has heard evidence before about at some point there is a balancing of decisions. One can close restaurants, one can close other things, and they all have an effect, and it's a cumulative effect which is ultimately being taken into account. If there is a socio-economic correlation, do you think that is to be avoided in terms of justification for locking down any particular areas, or would you accept that that would be, in particular circumstances, one means of distinguishing between where areas are closed down? That's a very poorly worded question. I think what I'm trying to say is if there are higher rates in areas of social deprivation, do you think that should be taken into account as a mitigating factor in terms of any decisions that are taken?
So there were strong inequalities in death rates by area deprivation, particularly in the first wave across the UK, but also specifically within Scotland. So the ratio was about 2.3, so about twice. The death rate was about twice as high in the most deprived 20% of areas in Scotland in wave 1. But by wave 2 that had fallen, and then it falls over time to be about 1.5 times, so a big reduction by 2023. Some of which is to do with the nature of the virus itself, and some of which is to do with vaccination programme. So there are inequalities in the impact of the virus, but equally we then get inequalities, some of which we've rehearsed, in the impact of restrictions and lockdown. And even within the lockdown, you have a lot of low-paid people living in deprived neighbourhoods who are key workers and still going out and being exposed. So it's almost that if you were to lock down, how much of that neighbourhood is actually, quote, locked down, because a lot of them would still be having to go about into the key worker. So I think it's a difficult balance because we don't necessarily fully understand. Is it to do with higher exposure in those neighbourhoods, because a lot of them are still going to work? Is it to do then with transmission within, for example, multi-generational households, households that are more likely to be overcrowded, smaller compared to in more affluent areas? Is it to do with vulnerabilities in terms of clinical comorbidities and so on? Or is it also to do with some knowledge that we have, for example, from flu studies of flu, is that people from more deprived communities, when they have flu, are more likely to have adverse outcomes from that, even when you control for pre-existing conditions, so kind of a susceptibility. So it's a complicated web as to why these inequalities emerged. So that makes it difficult for me to say simply yes or no to that kind of approach. It is, to use your own words, a balancing.
Do you think, and I appreciate that you can't come to a conclusion, it's not a yes-no answer, I appreciate, but do you think that it would be an appropriate consideration when one is considering the data that is being used to reach any conclusions? And we've talked at length about the R number. If the R number is being looked at across a population, then that will potentially impact or be impacted upon from areas where the R number is higher and potentially the R number is lower. But do you think it is a factor that should be taken into consideration that it may be acceptable to not impose as adverse restrictions on an area simply because it is socially economically deprived?
Regardless of its R number, so just because we think that that community might be more at risk, you in effect kind of cocoon that community.
Well, what I'm saying is, I suppose if one is trying to, I shouted to you, go to the R number because no doubt Professor Woolhouse will tell me that's not the data we should be talking about. But for ease of reference, if one assumes that you are seeking to bring the R number down across the country, and one of the easiest ways of doing that might be, as we discussed, to have a geographical lockdown of the places where the R number is the highest. The alternative to that might be to lock down, for example, and I shouldn't use the word lockdown in this context, but a lockdown or measures across the country to bring the R number down across the country, even where the R number might not necessarily be high, but affecting the impact across the country. Do you think it's appropriate in taking a decision as to whether to concentrate on potentially socio-economic areas where the R number is high, as opposed to taking universal measures to take into the fact that that R number might be high because of existing social inequalities? I potentially, maybe by way of example.
I'm not sure this is a question actually for me, because this is then about, you don't have an isolated socially, economically deprived area. They're going to be surrounded by other types of areas. So if, I don't know, Greater Manchester's having problems or Glasgow's having problems, you don't go in and just say, right, we just have the restrictions on this one neighbourhood of, like, I don't know, 20 streets. I can't see how that would be effective. But again, I'm not the infectious disease spread expert. You have 3 of them here.
But to take your example, for example, the lockdown of the north, if one was looking at wanting to reduce the infection rate across the country, one could have had a universal lockdown in the way that London was. But a decision was taken to lock down Manchester. Do you think, for example, the socio-economic situation in Manchester could have been taken into account or should have been taken into account?
I think my view on that, within line with my expertise, would have been that if you were choosing to do that because of your knowledge of the spread of the disease, which, as I said, would be out with my expertise, then you would need to ensure that it was possible for people to, in effect, deal with and experience that lockdown. So, famously around, the financial costs that was obviously going to have to places like Manchester and indeed the North East where I reside.
Thank you.
Our geographical area is not actually rather crude, because, and I think you implied it, if not said it directly, within a socially deprived area, there may be pockets of affluence. Within affluent areas, the exact opposite. And in fact, I think probably all our knowledge would give us examples of that. And therefore, whilst it's a very difficult question, as you have made clear, there is an element of the arbitrary in selecting any area for differentiation in relation to restrictions. Do you agree?
I think, Your Lordship, one of the reasons that geographical areas are picked on is because, and this comes back to some of the other issues we've discussed around our data that we have in the United Kingdom, slightly different between the 4 nations, but broadly our best data is based by geography. So hence I'll talk about deprivation more than low-income individuals, because we don't actually know that much about individuals, but we do know about neighbourhoods. But you're right, there is that issue around not everyone who lives in a deprived area is themselves deprived, and that can obviously vary. So, but our data comes from geographical areas, so that ends up being quite important in what we are able to measure. And then also our health system and our public health provision. Public health is largely through a local authority or health board geography, and then equally NHS provision is also geographically bounded to some extent. So I think that's why there is that kind of implicit focus within public health community.
I see.
From my perspective.
Professor Heyman?
Yes, whenever there's an increase in the number of cases or deaths, this requires a really good understanding of why this is occurring. And really to just use a blunt tool to lock down when you haven't done an investigation to see if you can stop it by other means, such as shutting down a gathering of people that's occurring on a routine basis, or understanding that the people themselves don't understand how they can prevent infection, is really the easy way out. It's the way that shouldn't be done. The way that should be done is government's role is to understand why this is occurring, and the surgical procedures, if you would, that can be used to decrease the transmission. So it's not using a blunt tool, it's using basic public health and epidemiology.
Thank you. I'd like to move on, if we may. We have just 20 minutes before lunch. The last topic I'd like to talk about this morning is about the approach to decision making. His Lordship last week heard from the experts from Sweden and New Zealand regarding the ways that decisions were made here, there. Professor Woolhouse, you obviously had some direct involvement in terms of dealing with politicians and decision making. But more objectively than that, I wonder if you have any thoughts as to how decisions were made and how decisions could and perhaps should be made in respect of any future pandemic, particularly mindful that His Lordship is seeking to learn lessons and that we don't really wish to fight the last war, to fight the future. If I could perhaps come to you first, Professor Heyman.
In looking what went on in countries that were the outliers, Sweden, for example, in Sweden, as I understand from their government advisors, there was actually a daily review of what was going on and looking to see where there were problems and how they could solve those problems. It was more of the government took the role of understanding what they needed to do to decrease transmission or to keep the people able to do that themselves. So they put the responsibility on people, and they facilitated what people were doing by requiring certain things such as spacing of tables in restaurants and different activities such as this, plus doing what their role really was to shut down those mass gatherings where they knew transmission could occur and could be a risk. In New Zealand, when I spoke with the New Zealand groups periodically, because I have a colleague in New Zealand, they at first said we can eradicate this infection, and that was not my understanding at that time because of the fact that other coronaviruses did not give a sterilizing immunity, and therefore you could not eradicate the infection. And then the messaging changed till after the vaccine came that we will continue to lock down until we can get our populations vaccinated. That was my understanding of what went on in New Zealand. So in New Zealand, the government took a more active, clearly active, blunt role, whereas in Sweden, it was more of an incisive role, looking to see what needed to be done and then helping the population do that.
Do you think, looking at the Swedish role in particular, medical scientists, epidemiologists have a more direct role in Sweden in terms of the decision-making process? Do you think this is something, pandemic response I'm talking about, where potentially political machinations need to be taken out of that equation?
I think in Sweden they were able to do that. That's quite difficult to do, but they have a very strong public health agency, respected, and they were able to do that. Whereas in other places, such as in the U.S., which has a very strong public health agency, they were not the spokesperson. They were not able to have an impact. So I think it depends on all the dynamics of the political leaders and the public health leaders, whether or not they can come to an agreement which permits public health to rule in making the decisions.
If you were to design a system, what would you be advising somebody to do?
If I were to design a system of public health in a country, I would design a system which had the independence to make decisions and to make recommendations, and which also became the public face of the pandemic or the outbreak. I once learned early in my career that every epidemic needs an honest face. And I think that the honest face, the best honest face, comes from those who have the evidence and apply the evidence, and that's usually in the public health agencies. So I think they must be empowered to do the job. Whether or not governments want that is a decision for the government to make. But in my view, the strong public health agency in Sweden was able to dominate in decision-making, whereas in New Zealand, the decisions were made mainly by government and academic institutions, especially in the academics who were pushing for initially eradication.
Thank you. Professor Gupta?
Well, I mean, little I can add to that. I mean, at some level, I suppose, I would want a complete overhaul of how political decisions are made, or how government makes decisions, and try and return to, I think, older systems where they weren't entirely political, that actually we were addressing the question at hand. I'd like the government to become once again a sort of a body that enacts the social contract, but those are sort of kind of, maybe it's just wishful thinking, you could even call it. But given that governments now seem to act in different ways than that which I kind of thought to be the role of government, I suppose the least I could ask is that perhaps in addition to having some sort of public health authority providing more input, that a diversity of opinion is solicited. In my personal experience, that was something that was suppressed. And that's not to say, oh, well, we were right and we weren't allowed to say anything at all. It's more that unless you permit a diversity of opinion, none of the alternatives will be on the table, of which one may be more preferable, and whichever is preferable, that knowledge will only arise through an interaction between the people who have particular views on how it might be controlled. And, the opportunities for that have not been provided by the government or the public health agencies or the learned bodies. That there's just been shutting down debate is probably the worst thing that could happen. Obviously, I speak to someone who was shut down, but I'm sure I'd like to believe that I can say this more broadly. As a general principle, shutting down debate is really quite ruinous.
Thank you. Professor Woolhouse, do you have any views on the way that decisions could or should be taken?
I do. First of all, I would like to endorse what Sinetra just said. I think the diversity of opinion absolutely should be out there. One of the faults with the scientific advisory system in the UK was that it put great emphasis on consensus, giving government a single message. And that's fine when there is a clear, unambiguous, universally agreed single message. But obviously, there was not in the early stages of COVID. How could there be? We simply did not have the understanding. But in every committee I was on, what they tried to do was take everyone's opinion and hone it down till they had a single message. And I think that was entirely the wrong thing to do. I think the government should have been given options and their pros and cons and allowed to choose between them. I think Sinetra and I are in agreement about that. I would like to underline a few of the things David said because they were important. I think one of the flaws was the tendency of politicians to micromanage during COVID-19. While this was popular in one respects, I personally did not want my First Minister opining on the number of people who could be allowed to queue outside a takeaway. That's not the sort of problem I wanted my First Minister to be thinking about during a crisis of this scale, nor did I want a senior cabinet minister down south to be opining on whether a Scotch egg constituted a substantial meal and allowed someone to go to a pub or not. This is absolutely not the sorts of questions they should be thinking about at the time. Those sorts of decisions are absolutely within the domain of the public health agencies, just as David said. But the agencies do have to be up to the task. Now, I agree. My assessment of Sweden is they actually did have very powerful, I think is the right word, public health agencies, who clearly were up to the task.
In Scotland, sadly, we didn't at the time, and I don't think we do now. I think within our public health agencies we have the wrong culture, the wrong leadership. They're very bureaucratic organisations, and they're the complete antithesis of being on the front foot. And this is particularly important in the early stages of the pandemic, and you asked me some questions about the advice I was giving in those early stages. That's where you want your public health agencies to be taking the lead. But in Scotland, we don't have public health agencies that do that. We didn't then, we don't now.
In terms of that single message, does that impact on, well, two questions, I suppose. When we're told the government is following the science, and in terms of ability to deviate from any chosen path, does that single message impact on the outlook and knowledge of the decision makers?
Well, it does. I mean, following the science is basically the politicians hiding behind the scientists and passing on responsibility to them. That said, I think some scientists during the time were very willing to take on that responsibility. So they weren't advising, they were advocating. And I think there's a fundamental difference in those rules. And I think that was a place where the advisory system fell down. It turned into an advocacy system. That's not what it should be. This is tied in with the consensus, the single message. So I don't think that's right. The counter to following the science is something one of my sage colleagues said in the epidemic, is the role of the scientific advisor in an emergency like this is to help the government do everything slightly less wrong. And I think that's actually a more realistic ambition for a scientific advisor, frankly, than have the government following the science. But somewhere between those two extremes is the reality. It's a bit of both.
Thank you. Professor Heyman, you wanted to come in?
Yes. I came to understand during the pandemic that there was actually another universe which was also working on making sure that their populations were safe, and that was the multinationals, who were developing, much to their frustration, ways that they felt they could keep their workers safe and keep them at work, yet they were unable to do so because of government policies. And so there was very little listening to what they were doing, and as we know, the private sector is many times very innovative and develops very innovative ways of preventing, in this instance, people from becoming infected on their ventilation systems, on their seating systems, on a whole series of things. And there was great frustration that they didn't really feel they had a voice in making the decisions within the country. Whether or not that's true or not, I don't know, because I wasn't on the advisory committees, but I was told that they didn't have a place on the advisory committees, and they therefore weren't able to really participate. And it brings to mind, during the SARS outbreak in 2003, the IATA, the airline industry, was very interested in understanding what was going on, and actually were able to contribute many ideas to what was developing within the World Health Organization on how to make sure that international travel didn't spread infection further than it did. So I think multinationals, the private sector, is a very important player in this and could do much innovation to stop transmission or to protect their own people, and weren't, in many instances, permitted to do that.
Thank you. Professor Bamborough, do you have any views in terms of the decision-making approaches?
Yeah, so obviously I wasn't involved in any of it, so I'm only aware of what's in the public domain. So obviously, like evidence here and at the UK inquiry, and but I also mean, looking at the planning documents and the minutes of things like SAGE and so on. But certainly, what's come through that is that there was a lack of consideration of what I would broadly call equality and diversity issues. So the things I've talked about in terms of how, you have this intervention, this plan, but it's going to play out differently for different communities, and there was a clear kind of lack of thinking through what that might be. Some of the reasons for that, I think, were who was round the table, so it's very much scientific advisors. Well, great, but you're implementing social measures. So it would probably be beneficial to have people that understand behaviour change, for example, equality issues, but also people on the ground. So some of the big charities, for example, who working with children or other communities that might be vulnerable, and also perhaps crucially our own directors of public health who are then having to in effect implement it, but also who know their own areas and what might play out. I mean, I think we all have some anecdotes, but one that I was told was that in one of the meetings there was a confusion as to why Sunderland had such high infection rates, high number of cases at one point, and that was because there was a misunderstanding in Whitehall, and they thought it was Sunderland in Cumbria, which is a tiny village, versus Sunderland in the northeast of England, which is a large conurbation and very deprived. That may or may not be true, but it's illustrative, I think, of that centralisation. I don't know the extent to which that happened in Scotland, but certainly with the UK evidence, I think there was a lack of diversity of opinions from that perspective, but also, like I say, people able to represent and think about the implications, for women, for carers, for people on a low income, for people of different cultural backgrounds. That is lacking from what I've seen.
We discussed, and you mentioned on a couple of occasions, the need for impact assessments.
Mm-hmm.
Do you have any comment on the role or the preparation that might be put in place in respect of that?
I would personally feel that they should be mandated in terms of policy, the people implementing the interventions. It should be like a compulsory part. It should be done a priori as far as possible within pandemic preparations, i.e. now we can start thinking about it based on the knowledge that we have from this and indeed from other pandemics, but also keeping it updated and rolling throughout should be something. But also it needs to be something that isn't just, often I think equality assessments are done and then they're put in a different filing cabinet and forgotten about. And when it's something as crucial as this, that can't be the case. I mean, it is routine practice to have equality assessments on many other government policies, but seemingly not when it comes to something arguably probably the most significant event in our lifetimes, to be honest, from a health perspective.
Thank you. My Lord, I have indicated to the panel that I will give them an opportunity to make any final comments at the end of the day. As I discussed on opening, we are allowing some time this afternoon for some Rule 9s, and as Your Lordship indicated at the commencement of the hearing, those are expected to be received by 12:30 today to allow consideration by Your Lordship in advance. Other than that, my Lord, I would propose breaking for lunch.
Very good. And we're having a longer lunch break to accommodate receiving any Rule 9 questions and considering the answers. So we'll come back at 1:45, so we've got more time to relax.